Hi guys, good afternoon. Today we're going to talk about atropine and glycopyrrolate. We're going to look at the presentation and mechanism, a little bit on usage and effects, and some pharmacokinetics. If we start off with the presentation, both of these drugs are anticholinergic agents. That means they antagonize muscarinic receptors, but it's important to note they have limited action against nicotinic receptors. Atropine is a naturally occurring tertiary amine, and its esters are formed by a combination of tropic acid and an organic base, and this allows it to cross the blood-brain barrier and allows it to exert central anticholinergic effects. In contrast to that, glycopyrrolate is a synthetic quaternary amine and has a charge and therefore is unable to cross the blood-brain barrier and indeed the placenta either. When we think about the presentation of both drugs, atropine is a clear solution. It comes in 600 micrograms per ml and the ampule size is 1 ml. Glycopyrrolate comes in a 200 microgram per ml mixture, and that's classically comes in a 3 ml ampule. Atropine is a racemic mix, however the only active isomer is 1-atropine. When we think about the usages of atropine specifically, atropine is used to treat bradycardia, and it's also got an anti-sialagogue property, i.e. it reduces the production of saliva. It's often used also as an antagonist for muscarinic side effects of anticholinergic agents such as neostigmine. Centrally, it causes less sedation and less amnesia than that of hyoscine. Bradycardia can precede the tachycardic effects which atropine is typically associated with. It can cause a bronchodilatory effect, more so than hyoscine. It can cause a loosening of the lower esophageal sphincter, and it can also provoke pyrexia in paediatric patients. Conversely, glycopyrrolate, when we think about the usage and effects, it's used as an anti-sialagogue. It's also used to treat bradycardias intraoperatively, and again, like atropine, the unwanted side effects of anticholinesterases. And typically you'll use a neostigmine glycopyrrolate combination agent in the reversal of neuromuscular blockade at the end of an operating procedure. When we think about the pharmacokinetics, atropine is intestinally absorbed. It's rapidly absorbed, but it is unpredictably absorbed. It's 50% plasma protein bound, and it's extensively metabolized by liver esterases, with a small fraction untouched excreted in the urine. When we think about the pharmacokinetics of glycopyrrolate, the intestinal absorption is negligible and oral bioavailability is significantly less. As we said, it doesn't cross the blood-brain barrier, and it is minimally metabolized, and 80% is excreted in the urine, unchanged from its original absorptional state.